Everyone, this is Lola. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center, or MHTTC. Please feel free to introduce yourself in the chat box if you'd like. And now I just want to go over a few housekeeping items before we get started. Next slide, please. Participant microphones have been muted at entry. If you have questions during the event, please use the chat. If you're having technical difficulties, you can message me privately. This session is being recorded and it will be emailed to all participants once it becomes available on the website. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of the month, we will send you a certificate of completion that you can submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information on CEs after the event. Next slide, please. This slide includes some MHTTC disclaimers. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and consistent with our actions, policies, and products. And with that, I will hand it over to Dr. Shirley Yen for some introductions.
Thank you, Lola. It is my absolute pleasure to introduce my friend and colleague, Dr. Lois Choi-Kain. Dr. Choi-Kain is currently the director of the Gunderson Personality Disorders Institute. She's the author of 3 books, a PI, a co-investigator, and a collaborator on a number of NIMH and donor-funded grants related to borderline personality disorder. Dr. Choi-Kain also founded the Gunderson Residence, an intensive residential treatment program combining various empirically supported therapies with a milieu setting emphasizing rehabilitation of social and occupational functioning. And in her decades-long tenure as founding program and medical director, she implemented or supervised the treatment of approximately 300 suicidal individuals with severe personality disorders, as well as complex comorbidity. She also developed a training institute offering CME-accredited trainings in MBT, DBT, DBT-PTSD, transference-focused psychotherapy, and good psychiatric management, or GPM. Dr. Choi-Kain has unique expertise regarding these many approaches and enabling her to bring together their common factors in a generic form of more widely available treatment. Thank you so much for joining us today, Dr. Choi-Kain. I'll hand it over to you.
Thank you so much, Shirley. It's just so meaningful to be here today. I don't know if you know this, Shirley, but tomorrow is the 5-year anniversary of John Gunderson's death. And he actually trained at Mass Mental. So being here this week is extremely meaningful to me. And I'm glad to be with all of you in this long historical thread of people working to provide mental health care for the severely mental ill in the community. And that I think you can feel good about. So I'm going to talk about integrating DBT and GPM. And the reason I'm doing this is because actually tomorrow I'm also giving grand rounds at BIDMC, and I will be talking more primarily about GPM then. But why I think this is important is that DBT is such a household name when it comes to self-harming, suicidal, and borderline personality disorder problems in the clinical world. And really, the story of how GPM emerged has a lot to do with DBT, which I'll tell you about as I go. So my conflicts of interest are that I have written these books for which I get some royalties. And if I mention any medications, of course, they'll be off-label because there are no FDA-indicated medications for borderline personality disorder. But let me put this into historical context. There was good news in the world when we found treatments that could be effective for working with people who live with borderline personality disorder, which was and still is to some extent thought to be untreatable. So in the 1990s, a number of treatments emerged because of the commitment of these treatment developers to do research, to put these treatments to test. So the well-known treatments such as dialectical behavioral therapy and mentalization-based treatments were put to test in randomized controlled trials against treatment as usual, which back in the 90s, I think we can kind of qualify as what they would call terrible as usual, because it was back in a time where people were pretty pessimistic about the treatability of this group of people. Similarly, STEPS, if you don't know that treatment, that's kind of like a simplified version of DBT that's packaged up in a 20-session group adjunctive therapy. So back then, the world was coming into some sort of attitudinal shift that there could be treatments, if they were actually tailored for BPD, that could be effective at reducing its most problematic symptoms. Now, once we found this out, I think leading with Marsha Linehan, investigators wanted to put it to more rigorous test because, of course, a treatment that's built for a problem is going to work better than a treatment that isn't quite designed for that, especially if it's very intensive. So Marsha Linehan put dialectical behavioral therapy to test against treatment by community experts. It wasn't manualized and it wasn't necessarily built for BPD, but it was administered by people who were known to be good at treating these patients. Similarly, TFP, transference-focused psychotherapy, went up against experts in the community. Schema-focused went up against TFP, and TFP went up against DBT and supportive. And actually what happened in this decade of research is that we found out the margin of difference is a lot lower when you put a good comparator up to any of these specialized, albeit effective treatments for BPD. But then more recently, the comparators got even more structured and organized. And treatments like dialectical behavioral therapy and MBT went up against informed, structured, generalist approaches for borderline personality disorder, which were administered by people who liked treating these patients. And the interesting thing was that there were virtually no differences. And I'll tell you about that. Similarly, MBT was trialed against a supportive form of therapy, and there was a dismantling study that also showed us that maybe you don't need the whole package of DBT to get the results that most patients need. The problem with advances made in our world now, that there are all these specialized treatments, is that there's just a siloing. So that while we have a better attitude towards people who live with BPD in terms of their prognosis, we don't have actually direct access to connect them with services that would be kind of considered definitive for them. And even I have this phenomenon when I contact my friends to make a referral, even if they will call me back in a heartbeat for something else, there seems to be a little bit of a lag when I'm trying to make a referral, partly because nobody has space and a lot of people only want to take so many patients into their practice that have BPD or that they need to administer one of these specialized treatments for. Now, meta-analytic studies have been done that show us, yes, in fact, that treatments that are designed for the problems of borderline personality disorder in general do better than treatment as usual. The problem is there's no evidence meta-analytically that any of these treatments are superior to each other, and that there's no evidence that they are better at retaining patients over all these studies than the comparison. Now, the interesting thing is with all the work that goes into something like DBT, MBT, or TFP, the effect sizes are small to moderate for standalone designs, like these intensive packages of individual and group therapy. More recently, meta-analytic approaches, such as this one done by the authors of the Cochrane Review that was published in the British Journal of Psychiatry, they've actually done a more finer grain analyses of some of these studies, and you see that they're effective in different ways. So DBT as a standalone treatment seems to be effective at reducing self-harm, improving psychosocial functioning, and reducing anger. And you can see how across the board these things do a smattering of things. But look at groups. when they look at add-on treatments, look at DBT skills group. That just does has a broad range of effects that everyone could harness. Now, I'm fond of psychoeducation. There's just not a lot of studies on that yet in the literature, but STEPS 2 does pretty well. So there's something about teaching patients to do something differently to solve their own problems that we need to pay attention to. So it's these studies that kind of point the way towards the clinical reality that we're not going to be able to provide the ideal gold standard to everyone, but we might be able to use some combination of things that we can make practicable and scalable that will be good enough and provide more just distribution of something that can work. Now, there are advantages to using evidence-based kind of frameworks for deciding what to use in treatment, and there are disadvantages because, let's face it, the psychotherapy research is limited. And this is kind of a cartoon about the different problems with it, that overall it's like everything works equally well or equally poorly, and we can just fight about it. And these trials are, after all, done on a very small number of white middle-class adults who got this full course of gold standard therapy and felt better than a matched group of non-troubled people who were ignored for 6 months. This is not a huge punchline. And there are other limitations. First of all, there is a obvious limited access to these treatments. The demand just infinitely exceeds the supply and always will. This will never be fixed. So we need generalist care to improve access, and we need to scale down the evidence-based treatments that we now apply so that we can have more of it to go around, because we don't know what dosing is actually kind of minimally required for the effectiveness. Even when people do get into these treatments, there are still profoundly high dropout rates, even though this is not that high for psychotherapies, especially for patients who are behaviorally unstable and interpersonally sensitive. Still, for something that's so intensive, having this degree of dropout gives us some cause to really think about whether or not that's the only thing we can do. And furthermore, some studies suggest that the non-response rate is quite high. And ironically, what I find in my supervision of specialist treatment centers is that just because you're doing a gold standard evidence-based treatment doesn't mean the patient is going to get better. And in fact, a lot of the factors that got the patient into that treatment to begin with also predict their non-responsiveness. So while this can help, it's got limited results in terms of these other factors. And why do people drop out? The reason generally is that there's a dissatisfaction with the treatment. There's no one size fits all. Some patients like DBT, some patients don't. Some patients prefer less treatment, like steps. It depends on the individual and the individual's context. And these dropouts tend to happen pretty quickly. The patient and the clinician usually get a feel for the problems pretty early on. So we're going to have to do something to diversify the choices that we as clinical professionals have and that patients also can access. Now, this brings us to DBT, to GPM. So the funny thing about GPM is that John Gunderson was not involved in this trial at all. But what did happen was Shelley McMahon, who's an amazing psychotherapy researcher and a foremost DBT expert, she was the first large methodologic trial PI outside of Marsha Linehan's lab to run this kind of definitive trial. It was methodologically pristine. It was an amazing trial. And she wanted a good comparator to distill the fact that it's the DBT that makes the difference. So she got Paul Links, who wrote the clinical guide with John Gunderson. He lent some help on the psychiatric portions while John wrote the lion's share of the clinical theorizing and the advisement, case management advisement. Paul Links actually ran the GPM arm based on APA guidelines and John Gunderson's clinical guide, which he assisted with. And the outcome of this study was shocking because GPM is a lot less treatment than DBT, which on average was 5 hours a week at least for each patient in this trial, whereas GPM was one single session, an hour-long session, and then an hour-and-a-half supervision for the clinicians in that arm. And you see here, there were no differences at the end of treatment in suicidal and non-suicidal self-injurious episodes, even though DBT specializes in this and GPM doesn't necessarily focus on it. And then in 2 years follow-up, you see there are no statistically significant differences. This was groundbreaking, because those of you who practice DBT, you know how much hard work this is. And what you'll notice about these graphs, although it's kind of impressionistic, is the blue is DBT. You see at 12 months' time when the treatment ends, there's an elbow. And it's like the treatment is like a partial program. It's like structuring, provides a lot to do. And when it ends, the kind of gains of it like plateau off, whereas GPM is a little bit more like of a fluid line. The lessons of it kind of keep yielding improvements over time. Now, McMain and her colleagues did some sub-analyses of this large trial that really had good data collected, and they looked at the trajectories of change. And what they found is that most people actually in this trial did pretty well. They rapidly recovered. But then there was also a group that recovered but were slower. That's a much smaller group. But the most interesting group is group 3, that they recovered and they looked like they had good outcomes at the end, but then relapsed. And trying to predict who ends up in each group is important. So what they did is look at a multinomial logistic regression. And what they found is that people who were more depressed, more emergency room visits at baseline, and less likely to be employed are more likely to be in this rapid improvement and rapid regression group, because the DBT provides a lot, or the GPM provides a lot, and then when it's over, they kind of go back to where they were. The gains aren't kind of sustained or internalized. Whereas these other people who have like reasonable loadings of depression, not so many emergency room visits, and some kind of meaningful activity, they were likely to respond better to either treatment. Now, they did another analysis of this data set looking at a personalized advantage index to see if there was an advantage of assigning one treatment over the other to certain patients. And what they found was that actually GPM was better for patients who had greater psychiatric symptom severity and more impulsivity. Whereas patients who had childhood emotional abuse, dependent personality traits, poor social adjustment, and higher depression rates or severities did better in DBT, but this only mattered for about 60% of the sample. For 40%, it doesn't matter which one you put them in. They'll do well in whatever, but there may be some advantages of putting one person in one over the other based on their clinical profile at baseline. And more research prospectively is needed for that. This was done post-hoc. And lastly, the kind of lesson of this trial is that even though these patients symptomatically remitted on the whole, 2/3 of them remitted, a lot of them remained disabled and a lot of them remained unemployed. And I think that is actually a context that keeps people on the margins of society and makes them lack a sense of belonging, structure, regulation, and connection to others that feeds into the ongoing problems of personality disorder and deplete meaning in life. And in this trial, work was not emphasized in either the DBT or GPM arm, but in clinical practice it is, and now this is a central part of GPM. So when John heard the results, I actually was here in his office when he had first heard, and he said that Marsha Linehan had contacted him and said, guess what, your treatment works as well as mine. And he, of course, being John Gunderson, he gloated a bit and he took a victory lap. And he's kind of like joking around and he's very mischievous. But I think there is some truth to this victory of saying, even if you don't know Marsha Linehan and you don't know the 43 or 635 skills that DBT now involves in its second edition, you don't need to despair that you can't get better or you can't treat patients with BPD. So what is GPM? Now, GPM, the version that was in the trial was called General Psychiatric Management because a generalist clinician in mental health can practice it. Now, he called it good based on this book because he just wanted to convey that it's good enough. It's not like the end all and be all, but it should be what we at baseline fundamentally provide patients. They deserve that. Since BPD is so prevalent, severe, disabling, and sometimes fatal, all mental health professionals should be equipped to provide good psychiatric management. And you don't have to be a psychiatrist to do this treatment. Now, GPM takes common factors. It really focuses on boiling down what really works amongst all the treatments, and then sprinkles in things that are distinctive of each. So GPM occupies a central position here. It is behavioral because it holds the treatment and the patient accountable for changing what they do. That is the central outcome that we want to see happen. We do practical problem solving. We give them homework to do because they have to live their life and solve their problems outside of sessions. It incorporates an MBT non-authoritarian stance where you're not knowing, you're curious about things, how things work, and you want to promote stable attachments that work to empower someone as a secure base to explore the world and learn about it. And from TFP, transference-focused psychotherapy, based on Otto Kernberg's work, there's an incorporation of the process of anger and devaluation. And there's not a shyness or an inhibition of saying, I don't know, maybe I'm wrong, but this is my interpretation. What do you think? But you don't use the interpretation as definitely equivalent to reality, like you have a monopoly on that. So this actually encompasses a lot of the basics of what works, but what I think it has distinctively is a theoretical formulation of how all the symptoms go together, just like the other treatments. So in DBT, they say emotion dysregulation is the core engine that determines all the other problems. In mentalization, it's a mentalization instability that determines the constellation of problems in BPD. In TFP, it's split object relations and identity diffusion. In GPM, it's interpersonal hypersensitivity. And this is based on John Gunderson's both psychodynamic background in his years at Mass Mental in the 70s when he was here, and also his years conducting impactful research that really revolutionized how we practice care for BPD today. So this is how he thought it worked. And he wrote about this a long time ago in the 80s, before DBT or any of these things came out. He thought that people with BPD were intolerant of aloneness. And they're so kind of sensitive and needing someone to be there for them to feel like they're okay. So when they're connected, they're idealizing, they're dependent, but because they're not self-reliant or confident about their own abilities to survive without that relationship, they're hyper-vigilant and anxious. So invariably, any disagreement, threat of separation, all sorts of normal things that happen in relationships will be an interpersonal stressor that then puts the person in a threatened state, whether it's real or perceived. And when any of us are threatened, we go into fight or flight, right? And the fight part being the angry devaluation and the aggressive behaviors, and the flight being the self-injurious, self-critical anger turned inward. And this is where deliberate self-harm comes in, is that there may be some effort to kind of futilely cope in the moment that's not meant to end life, but is a kind of lashing out or lashing in the face of this threat. Now, the problem with this fight or flight reaction is it's not pro-social. Either way, this disrupts the attachment and connection to others because they either get confused and scared or they get annoyed and angry. And they tend to actually withdraw. It's the very abandonment that this interpersonally hypersensitive person is fearing. And because patients with BPD haven't internalized a sense of self-confidence or goodness or an ability to rely on others. When they're alone, they're lost at sea. They have no anchor to reality and therefore become paranoid and also don't appreciate the consequences of their impulsive and reckless action. Now, this is where we start to pay attention to them, but it's too late. They're not able to kind of organize their psychological and neurocognitive systems to cooperate. And in this kind of flailing lack of holding, of course, people feel despair. And this is when more dangerous suicidality comes out. Unfortunately, that's where we tend to see these patients most, and we become a holding environment to reconnect them when they're already past the point of collaboration. And unfortunately, we don't do the part of it that might keep them out of the hospital and the emergency room, which is doing something that keeps them between the connected and threatened states more stably and more workably so that they can build a life outside of the hospital. Now, GPM, therefore, tries to get clinicians to lean in when the patient's at the most threatened place. And this is so anti-intuitive, even though we're clinicians and we like working with people at their worst hour, clinicians are still afraid of anger. They're still afraid of self-injury. So doing this takes some encouragement and fortitude. And that's what we try to advance in the clinical approach of GPM. It's not so much about the content, it's about trying to manage the care so that when these signs start happening, you lean in. And so fighting is not a bad thing. It's being uncomfortably connected rather than comfortably connected, which has its downsides too. When you're idealized, that's not necessarily a good thing. And this is human. And whatever your political leanings, whatever happens here in the United States, I think there's a huge divide because there are problems of belonging on all sides of the equation. And when people feel unheard, they will do things that are neither adaptive and possibly destructive. So what's involved in GPM? It's pretty simple. You're all doing this for other disorders. Under the hood is just diagnosis and disclosure, psychoeducation, accountability for change, and an impetus to get a life. Because personality disorder, that is problems of managing oneself and others, is built and fostered through living life with work and love, like Freud said. So making a diagnosis is something we do with every other disorder, but there's such stigma and hesitation and insecurity around BPD that a lot of people think it's like a little bit like this, adding insult to injury. And when I first came to McLean in the 2000s, I mean, John Gunderson had the worst reputation ever. He was a pretty stressed out guy in his early years, and he was a little rough around the edges. But, you know, I think that people regarded telling someone that they had BPD like it was an insult rather than a kind of objective clinical assessment. But that's actually not what the data says. So this was a study done at McLean of people pre-diagnostic disclosure and then after, and their ratings of shame, likability, hope, and overall well-being. And the truth is, you have to have some perspective. If someone lives with BPD for a long time, their shame and likability isn't going to change with just finding out a diagnosis. But actually learning that people understand this problem and that they're not alone increases hope and overall well-being. And there's a lot of research now, like Mark Zimmerman's research at Brown, that shows that people who get the BPD diagnosis are no less satisfied with it than people who get other psychiatric diagnoses. But when you give a BPD diagnosis, you replace the person's notion that they're a loser or they're broken beyond repair or they're never going to be able to live their life in a happy way with an explanation of why they do the things they do. And we say this means you are born with a disposition that makes you hypersensitive in ways that would make it difficult for others to respond helpfully. This is an interpersonal process. It doesn't mean you're to blame, doesn't mean they're to blame, but there's a transaction that's difficult because there's sensitivity and misunderstanding. And we think when we locate the problem within the patient, it empowers them to do something differently about it. It's not to stigmatize them. And I personally find that insulting, because if you've worked with BPD patients, it is hard. I would rather work with other patients and make my life easier. But to then be told we're like stigmatizing them and blaming them is just, it leads to such a feeling of being misunderstood, because that's not at all what BPD treatments are meant to be like. Now, the psychoeducational approach is to confer hope. That is, from the longitudinal research that Dr. Yen was involved in, we know that BPD's rate of remission is actually pretty high. I think our clinical work brings us into interface with the patients who stay in the system because they're severe and non-responsive to the treatments we provide them. And maybe there's a problem with the treatments we provide. But those patients aren't representative of all people who have BPD, because many of them will go on with their merry lives because they do respond, even without DBT, MBT, or any of these three-letter treatments. But what we know is over 10 years' time, their level of average BPD criteria will go down. They don't go away completely, because there are probably some core traits that make them vulnerable to this disorder. And the most common residual feature is the tendency to be depressed and anxious when alone. But 4 out of 5 patients will remit by 10 years, and it's even higher, 26 years, that Mary has completed data collection on. And from CLIPS, we know even with remission, functional status does not improve. Now, the psychoeducation can be delivered in a variety of ways. Maria Rodolfi in Italy has done it in a 6-session group. Groups are great. The dismantling study showed that just the process of being with other people who have the same problem that you can talk about it with is awesome. And there's structure provided by the skills training. There's structure in this provided by the psychoeducation. So we talk about the symptoms, the longitudinal course, the treatments that work, the treatments that don't work, like medications, and family stuff, all these factors that are in GPM. You can do it in 6 sessions of group, and then the patients can personalize it with each other, how it applies to them. And this brief intervention actually reduced symptoms by 50% in almost half of the group in the intervention group. But when you looked at the waitlist comparison, only 3%, like maybe one patient in that group, 1 or 2 patients on the waitlist, had a 50% reduction in their BPD symptoms. So something about this group works. The next issue is accountability or expectation to change. And this is what makes it psychiatric, not because only psychiatrists do this, but it recruits a medical model, is that we understand the course of illnesses to scale our expectations to change. So if we know the natural course of BPD is to improve, the treatment should at least do that and not make things worse or keep things the same. And so just like any other intervention, if you take a medication for hypertension, you don't continue it if it's not working. We say we'll only continue this if it's actually working. And if it's not, we have to look at what we could do better. This actually addresses the problem that some patients feel like they have to be symptomatic in order to get care and support. And that's tragic that that's how they feel, but I can understand why that's the way. It's a broken system. But the accountability for change and saying our relationship and its effectiveness will be evaluated based on whether or not we relieve you of your symptoms and you increase your functioning. Because getting a life is the definitive solution. And because these patients are so interpersonally preoccupied, they will gravitate towards these love relationships. I almost fell off my rocker too with that one. But what we say is, okay, before you do that, because you're so hypersensitive to relationships and romance is going to knock any of us off our feet on a good day, get something more stabilizing, like a job. It's boring because it's stabilizing. And when you can do something independent that organizes your life and gives you a sense of purpose and value vis-a-vis a greater mission, whether it's paid or not paid or being part of an AA group or whatever, that may give you a sense of self independent from how a person feels about you. So we say you better work at something in any way that is available or meaningful to you. Take a role. And it's only less attractive version of John Gunderson saying it than RuPaul, who is extraordinarily beautiful. So this really kind of also kind of addresses this issue of disability, because John, being the PI of the CLIP study and finding this kind of marginal improvement in functioning in both longitudinal outcomes despite remission and in treatment studies, we really feel as a field that people need more help getting into structured activities to generalize their treatment gains to life outside of the consulting room. So that's all that's beneath the hood. GPM is simple. It takes what we generally do in mental health care. We focus on the interpersonal hypersensitivity and how it affects all the symptoms in BPD so that patients understand their social transactions, not as someone's there for me and is my hero, or someone's not there for me and is the worst devil I've ever met, but understanding things more transactionally. If I scream at my boss, they may not want to work with me. So that gives them a little bit of a window into the modifiable factor that they can work on. They can easily work on trying to do whatever it takes to reduce the likelihood they're going to scream at their boss. And if they can be more pro-social, that is a runway to making interpersonal interactions more satisfying and coherent. And that will enable people to get a life and deal with some of the primary handicaps of BPD so that they can get on the road of meaningful structures that promote their psychological growth over time. So what's in this toolkit? First of all, you have to learn how to manage safety if you're working with BPD. No good treatment for BPD will be absent of a safety management approach. And what we rely on are common factors that work across suicidal people, regardless of diagnosis. Use a crisis plan or safety plan that always helps, and assess dangerousness. We say, based on the interpersonal model, that suicidality and self-endangering behaviors are usually a reaction to interpersonal stress, the perception of rejection, or the fear of being alone. If you're overwhelmed with stressors and you're totally alone, I think any human being would feel more despairing and more prone to suicidality. So we use this model to understand these states and predict when they're this more self-harming sort versus the more despairing suicidal sort. And we say to patients, I can help you manage these behaviors, but to diminish their cause, we need to help you find a better set of social supports, not just me, people who can help you in these situations. When you're feeling down and stressed, rather than when it drops to the point of wanting to die. And then we understand the factors that generally increase risk or decrease risk for suicide attempts. Negative interpersonal events or stressful life events, increased substance use, increased depression, and step downs are times that people are generally at risk, and we have to factor that in. And support positive interpersonal contact, safety planning, crisis skills, sometimes low-dose temporary antipsychotics, and hospitalization can, in the short run, decrease risk if that's needed. But over the long run, repeated hospitalizations is associated with increased risk for completed suicide or dying by suicide. In GPM, we also have an algorithm for managing co-occurring disorders because BPD is necessarily complex. It's a reflection of low resilience and high chronicity. Because when you have the four symptom sectors of BPD, it's going to be hard for you to cope with stress. If your emotions go all over the place, you can't get the support you need, and you're impulsively self-destructive. So you want to prioritize BPD in the treatment when you have anxiety or mood disorders, because it will increase the likelihood of remission and decrease the likelihood of relapse. But there are conditions where you have to treat the other thing first to help the patient be in the highest cognitive operations so that they can learn and control their decision-making. So ADHD, mania, anorexia nervosa, those are things that drive cognitive, the depression of cognitive performance. You want to improve that. Sometimes complex PTSD is a factor because they may be too vigilant to get attached to someone in any treatment relationship. So you may need a more trauma-specialized approach in certain cases, not all. And sometimes with severe substance dependence, you have to get them detoxed first and stabilize them before treatment. So this is the schema of how you manage the care. It's not a psychotherapy, it's a clinical management approach. And this was informed by the CLIP study. John and his collaborators studied the interaction between BPD and a number of disorders that informed this way of working. Now, the last set of bubbles, the green ones, are pragmatic. That is that there's certain disorders like panic disorder, PTSD, and OCD where the primary treatments are exposure. So if you're going to amplify the stress and demand psychologically on the patient, and they have BPD, the likelihood they're going to do something that then adds problems onto the exposure is high. So sometimes you have to stabilize the BPD and give the patient some improvement of their BPD symptoms before embarking on these other treatments so that they can tolerate and make best use of those treatments. And of course, no medication work. There will never be a medication that works for interpersonal problems, emotional dysregulation, impulsive problems, and identity diffusion or problems of clarity about oneself. This is a kind of a cumulative outcome of a lot of factors where there was a high loading of adversity or demands without sufficient support or skills. So medications are not going to correct this. But what might correct this is some bridge to being a part of relationships that are of different sorts and provide an opportunity for adaptation. So GPM also includes recruiting a village to raise the child in terms of the patient's care and to remap out the person's development that they didn't have the full opportunity to kind of make use of because of the interruptions of having BPD. So you use a team approach so that everyone pitches in. If one person's the bad guy, there will always be others. And it's also a kind of product of trying not to put all your eggs in one basket. We try to support family involvement whenever possible and give them skills and tools and psychoeducation to do better to support their family member with BPD. And we promote socialization in groups, in AA, in the community, with the basic idea that you have to give to get what you want and you have to follow rules to be part of an organization. So the mechanisms are simple. Like I'll talk about this with the DBT when I touch on that briefly. Think first. That's across all the treatments that work for BPD. Think first, stop and think. 2, try things to correct your basic or core beliefs that you're bad and the world is bad. And try to get the patients to have a corrective experience of knowing that everyone's flawed and limited, but that's not a reason to give up. There's still something to offer. And we also want people to get a life because actually life itself gives you self-esteem and corrects these problems. And work and school gives you relationships that might endure. And this can be done creatively to scale it. We're working on a study of online video prescriptions, and we're currently recruiting for that study. So if you're interested in that, let me know. We have 10 prescription videos that we vend out daily, 5 days a week for 14 days, providing all this information. So if you want people to get in this trial, basically involves psychoeducation about BPD versus other videos that were made at McLean about other mental health problems, online assessment. Some of the subjects get feedback. And this is really with the idea that increased understanding about BPD and patterns that impact one's life empowers people to have a framework for thinking about oneself and others constructively and start their process of change. Now, my treatment of DBT here is going to be light because a lot of people know what DBT is, and there's no way in the world I'm going to teach you all of DBT, but I'm going to touch on some high points. DBT's main formulation is that people are born with a biological inclination to be emotionally sensitive, and interfacing with any not custom fit environment is invalidating and stressful for someone who's sensitive. So that actually makes for a situation where there's a misunderstanding between sides and the person who's sensitive can't understand the environment and the environment can't understand the person's sensitivity. And then they have this adverse interaction of externalization, blame, and denial. And that makes the person more emotionally hypersensitive. And this leaves the person's solution focused instead of empathic with the people around them, and vice versa. The system is not empathic to the person and tries to control them. And that's why there's a lot of behavioral processes or expressions of the problem. But there are a lot of things that lie underneath that drive those behaviors that need attention. And Marcia Linehan basically boils this down to avoidance and problems of communication. Those are two key areas that DBT skills are designed to interrupt and support more effective behavior. Because if you don't avoid negative emotions, you won't go back and forth between unrelenting crises and inhibited grieving. And if you can communicate better, you won't flip-flop between active passivity and apparent competence. And if you have some self-acceptance, mindfulness, and improvement in your effectiveness, you can deal with the problems of your emotional vulnerability so that it doesn't just cause self-invalidation. Now, like I said, there was this dismantling study, a very good and important study that Marcia was the PI of, that showed that actually, if you take the components of DBT, the skills training group seems to actually be pretty comparable to the full package. The individual does a little bit less well. So, I think that it's safe to say that DBT skills groups are good for people. I haven't seen them ever be that harmful. They do take time and they have homework to it. And now there's research suggesting that this can be done faster, that 6 months of DBT is not inferior to 12 months of DBT. That's good news. And I'm going to skip some of this, but basically my junior investigator, Jenna Trainer, who's moved to Boston, this paper was actually published recently, that actually in patients who had impaired inhibitory control on cognitive performance tasks actually did better in 6 months than 12 months. So even it's better for them to have a shorter DBT run. Now, on the flip side, a little DBT does not go a long way, because in a large healthcare study of 4 huge healthcare systems, they found that like an online skills training component for recurrently suicidal people in their healthcare system actually did worse than treatment as usual, and a care management approach that was modeled after collaborative care. This is kind of the survival analysis that you see in the top line. There was a quicker relapse to self-harming behaviors with the skills training, but this didn't really involve individual therapy or coaching. I do think we can be smart about what we use in DBT. First of all, just technically in managing the relationship, the 6 levels of validation are awesome. This would help anyone in any interaction. I think I could use this in my work with my colleagues here. So just trying to use different ways of showing someone that you're listening and you understand what they're saying is really helpful. I think this is a pearl of DBT. Now, I've added to this 6 levels of confrontation. John used to say to me, you know what? Anyone can be nice. You need training to be able to be a bad object and manage it constructively. So I think people need more help with the part on confrontation. So providing feedback is hard. People get anxious about it. So feedback that anyone would want to hear, like their zipper was down or that they have spinach in their teeth, that's hard for us to do for whatever reason. Feedback having to do about choices, like maybe those pants are right for you. I mean, you can think about whether or not you would want to do this, but just kind of for heuristics, I'm making this a little bit playful. But, trying to really be transparent with someone in a genuine and important way requires some support and practice. And we do need to teach clinicians skills about that. And I do think DBT as a package promotes the balance of validation and a push to change with these confrontational kinds of components of conversation. I think DBT also does well to create a process of committing to the work that I think any treatment for this disorder should model. That is, looking at both sides of what's the benefit of going to treatment and what are the costs. And there are all these commitment strategies I can't explain right now, but I think they're very useful regardless of whether or not you're using DBT. And also attention to the treatment interfering behaviors, because sometimes we're so focused on just trying to get treatment off the ground. We have to be very transparent and clear that sometimes we're not even doing treatment. We're just managing life interfering or treatment interfering behaviors. And we have to work on those things first before we get to the meat of what we're doing with a patient. Now, structure of the sessions is also really important with working with BPD patients. With unstructured treatments, there's regressions and a lack of containment. So in DBT, there's agenda setting, diary cards. That's a way of organizing the discussion that both people can anticipate and work with. And organizing a hierarchy of treatment strategies. I think that can be incorporated into any treatment. The one problem with this is that sometimes there's an overemphasis on not dangerous self-harm because of this, which can kind of consume the whole treatment. And in GPM, we would just let that go if the patient's goal was not to decrease their self-harm. Now, if you had to pick 10 DBT skills, Shelley McMean actually picked them out for us in this book on GPM and DBT. And she has a wonderful chapter in here where she talks about the utility of these 10 skills, even if you're not a DBT therapist, and if you run one DBT group that a lot of patients take, regardless of what main treatment they're in. And these include distress tolerance skills, not making things worse when you feel under pressure and you don't know what to do. And then mindfulness skills, that once that level of distress and the urges to do something self-sabotaging or destructive go down, paying attention to what is going on, how you're understanding it or processing it, and then being in wise mind when you make a decision. That is, having rationality and some awareness and clarity about your emotional inputs to the situation. And when you have a connection to your emotional experience, instead of having inhibited grieving or unrelenting crises, you have to regulate those emotions. And there's this whole kind of set of skills for that. And many of them are helpful in any treatment approach, even if you're not doing full DBT. And then having a framework for problem solving and doing the opposite of what your urge is. That is a very simple set of ideas that is very helpful in framing change. So this is, I think, very helpful if you had to pick a few DBT skills. And of course, I can't go through these all. And those of you who know DBT will know what these things are. But I'm happy to pass on a PDF of these slides if you want them. Lastly, because interpersonal problems are so distinguishing of BPD, I think it's great that DBT has this whole interpersonal effectiveness skill set. And if you just cover getting what you want, managing the relationship, and maintaining self-respect, those are domains I wish everybody in the world had better skills with. I certainly have benefited from these skills. It just gives you kind of a focus with how you can organize your thoughts and feelings about difficult interpersonal interactions. And just like with TFP, DBT also thinks about splitting and uses constructs like radical acceptance, accepting radically everything about a situation. Doesn't mean you agree, doesn't mean you like it, but you accept the situation as it is, all the feelings and thoughts that go with it, and you're mindful to it. And then you can, in wise mind, decide what you're going to do with it. So how do you organize all these things? There's a step care model that you can kind of think about. Maybe the more intensive things go in the middle, sustained or moderate level of BPD symptoms, but early, mild, or early intervention, you can just do GPM, maybe some DBT skills or steps. But my main message here is that with the chronic, persistent, severe patients, if they're not responding to the 10 things you did before, the likelihood they're going to respond to any other newfangled idea is low. So do something supportive, provide more contextual support, more services, and more rehabilitation. Less change, more stabilization. So just to tie this all together, all treatments for BPD, think about trying to stabilize the symptoms of BPD and then activate the patient to be able to live their life again so that there's new opportunities to learn and adapt the way they react to stress. And if you get their functioning off the ground, they're in the world and they can learn how to manage their emotions and social relationships and increase their social cognition and emotional intelligence and regulation. And then from having more capacity and capability and more experience in the world, their problems of identity fragmentation and negativity can be healed, where they can have a more coherent sense of self and more positive sense of themselves in the future. Because what we want to do is really promote functioning, give them responsibilities and goals, starting with the treatment to interrupt their crises. Because I had to come to work today, I didn't have time to loiter around and get in a fight with a random person. Or, you sometimes are like, oh, I don't have time to deal with this argument I might have otherwise because I have to get to grand rounds. Then with the behavioral activation, we try to require things of patients. Do your job, take your medication, or follow up with these groups, or let's figure out what's getting in the way. Let's work on things. Pay the patient some respect by expecting some things of them. That's a reflection that you think they're capable, and you want to work with them on learning what it takes to become a more capable version of themselves. And this will help them understand themselves vis-a-vis the world. So I hope this helps you have some basic tools so that you can see that these patients just have BPD. They are not borderline permanently, but you want to get them on the road of life so that they can have other aspects of their personality. So that is my talk.
Thank you so much, Lois. That was really excellent. I very much enjoyed seeing the images of John and the references to John. There's no doubt that he would be so pleased with how you're carrying on his legacy. So thank you very much. I'd like to open it up for questions from the audience. We do have a couple minutes. If you can enter that into the chat feature. And this, there will be a link to the recording. While we're waiting, I was wondering, do you happen to have an example of the leaning in that can, an example of uncomfortable leaning in?
Yeah.
And what that would look like?
Well, a funny example is that there was a patient who, sadly had like no awareness of how their behavior with their laundry was affecting their reception in the community. So they weren't doing their laundry and they had some malodorousness, and then people have found it hard to be around them. And socially, it's so kind of like uncomfortable to say, you are malodorous and people are having a hard time just being in the room with you. But just leaning into the problem and paying the person respect and expecting that they can handle it allows you to address the situation. Similarly, when the patient is screaming and yelling at you, trying to say, hold on, if you can kind of lower your voice, I actually want to hear what you have to say because there's some problem that's getting you really upset with me. Maybe I did something to set this off, but I want to know what it is. So can we talk about it? What do we need to do to help you lower your voice and not scream at me and tell me that I'm terrible? I got that I did something. So you lean in rather than be like, okay, why don't you go take a break and I'll come back when you're feeling better, that.
Right. Not sending them away to decrease or to regulate their emotions, but to sit with them.
Well, to try to figure it out. If they need to step out of the room to regulate and come back, that's okay. But the avoidant, aversion towards the patient because they're angry, that's what GPM would advise against.
Great. Thank you.
Yeah.
Any questions? There's one in the chat feature. What would you say to colleagues who feel that BPD is stigmatizing and avoid giving that diagnosis? I've run into the same problem and want to approach it collaboratively.
Well, part of the GPM mantra is that everyone has their own opinion. I generally say, you know, my opinion is that this person has BPD, and I see that as a constructive, optimistic starting point to organize the work that we can do together and strengthen the alliance. Because this person is struggling and suffering, and I want to put handles and clarity to that suffering by telling them they have something that a lot of people have that's treatable. And so if you can reframe it like that, you know, there's no other disorder in the world where people are like, oh, that's, I don't want to say that, or it's something else. Like if someone has trauma and substance use disorder, we don't say, oh, you don't really have a substance use disorder. It's just PTSD. I mean, but for BPD, because of its stigma and the idealization, devaluation dynamic that makes people protective and see other people as neglectful or abusive, that I think ties into this aversion to diagnosing people with BPD.
Great. Thank you so much, Lois. And finally, I know we're out of time. If you are recruiting for a study, if people have patients that meet the BPD criteria, should they get in touch with?
Yeah, we have the Gunderson PDI at mgb.org is our email. You can just email us, and it's on Rally, actually. If you're a part of Rally, you can point patients to that direction too.
Thank you so much.
Thank you, Shirley. Great to spend time with you on this week.
Nice to see you. Yes. Bye.